Assalamu alaikum wa rahmatullahi wa barakatuh. How are you all? So, as we said in the previous video, that shock is a life-threatening condition, and the patient mostly come with hypotension and other vital sign changes. So, we must know that the effects of shock can be reversible at the beginning, but can become irreversible rapidly. So the good doctor and the good physician must rapidly identify the cause and the type of the shock, so he can do an appropriate intervention to prevent the bad sequelae, as we say it, of shock that can lead to multi-organ failure and subsequently death. So, what is the management of a patient that present with shock? We have an initial approach. First of all, we must determine the goals of my management, because we know that when we have a shock, then we have not enough oxygen that reaching the tissues. So one of the first goals that we have is to restore the global oxygen delivery by ensuring an adequate cardiac output, as well as by maintaining a blood pressure, good blood pressure within the normal ranges, to ensure the adequate perfusion of the vital organs to prevent that organ failure, as well as avoid levels of left atrial pressure that can produce pulmonary edema, meaning prevent the complications of my management. Okay, so in this table we have the initial management of circulatory shock. So first of all, in the initial management of a patient with circulatory collapse or shock, we have to do what's called by ABC, and this is for making the patient stable. And after we determine the specific cause for the shock, we can proceed by our management accordingly. So ABC, as we know, means A means the airway assessment, so it should be stabilized and for optimal oxygenation, because patient may need an oxygen therapy and may need ventilation. But the ventilation can be considered in some indication, especially when we have an intractable hypoxemia, means that the oxygen it's not responding to oxygen therapy, or the partial CO2 is more than 50 millimmercury, and this is called by hypercapnia. Or the patient may have respiratory distress signs symptoms, or the patient is impaired conscious levels. This means that Glasgow coma score is less than 8, so the patient will have impaired conscious level and may need intubation and ventilation. So first of all is A, which is the airway assessment. B means the breathing assessment, okay, and this by looking for the chest sounds and securing the airway that are patent and so on, and the patient is muscle breathing is working effectively. And finally, we must assess the circulation by assessing the heart rate and the blood pressure. We might need a direct arterial pressure intra-arterial line to measure the blood pressure effectively, as well as the central venous pressure and peripheral perfusion. So we have to ensure an adequate IV access to be secured, because the patient may need an IV fluid to restore the adequate tissue perfusion. Okay, now according for up to date 2024, the approach for the patient with hypertension or shock, and this is the initial approach. So if the clinical condition is consistent with shock, this means that the patient come with hypertension and tachycardia and so on from the signs and symptoms that we said. If it was no, then we must search or looking for another alternative differential diagnosis, such as chronic hypertension or drug-induced hypertension or autoimmune dysfunction and so on. So here's the importance of very good and focused history taking and focused physical examination. But if the patient is yes consistent with the shock signs and symptoms, then as we said, we must do the first approach, which is stabilizing the patient before we determine the cause and the specific type of shock in order to manage it specifically. So first of all, we secure the airway and establish an IV access, okay, for taking a blood for lab study to support my diagnosis, as well as to give the patient an IV fluid to restore the intravenous blood volume in order to restore the adequate perfusion for tissues. So is life-saving, or we need an early intervention, means like we need the patient as if it was diagnosed with tension pneumothorax, so we might need to do a chest tube, or as we said, if there is a pericardial effusion, which is cardiac turbulence, very life-threatening condition, so we might need to do a pericardiocentesis, or the patient has an anaphylactic shock, so then we have to use an IV epinephrine, and so on. So is the patient, if yes, so we can proceed by this, and then is the patient stabilized? If no, we have to continue resuscitation. If yes, then now we do a focused clinical history and examination to determine the specific type of shock to proceed by my management. So after we stabilize the patient by ABC management, okay, airway assessment and breathing assessment, as well as circulatory support, and the patient heart rate, blood pressure, oxygenation is all good. Now we must to take a focused clinical history and examination in a stable patient with shock, and looking for which type of shock the patient has. So evidence for hypovolemic shock, like as we said, hemorrhage from trauma or GI bleeding, or ruptured aortic aneurysm. Aneurysm, it's a balloon like in the wall of the aorta. Or maybe the patient suffering from severe vomiting diarrhea, and so on. So we look for these evidence for hypovolemic shock. So the patient might need only giving IV fluid resuscitation. While on obstructive shock, the patient may have pleuritic chest pain and dyspnea to suggest a pneumothorax or pulmonary embolism. Elevated jugular venous distension, or right parasite heave, and this is will be revealed on a good examination. So we can manage according to the cause. If it is attention pneumothorax, we must do chest tube. If it's pulmonary embolism, we might give anticoagulant, and so on. What about the cardiogenic shock? If there is in the history a known cardiomyopathy, signs and symptoms of myocardial infarction, crushing chest pain, also elevated GVD, jugular venous distension, or lung crackles on auscultation, we must do ECG in any patient coming with shock, looking for arrhythmia, and so on. As well as for distributive shock, we looking for any possible septic source, such as the patient may come with a fever, okay, and so on, or allergies, okay, signs, symptoms of allergy, so it can be an anaphylactic shock. And the patient might have a combined shock, okay, signs and symptoms of hypovolemia as well as distributive shock. So the distributive shock here means the vasodilative shock, which might be septic, anaphylactic, or neurogenic. In addition to all of these, we must do every patient, we must do general lab studies to help me to reach my final diagnosis. Okay, we do a CBC, a kidney and liver function, because we know these are vital organs that can be affected first by shock. Serum lactate will be elevated in any shock patient, and this can strongly support my diagnosis of shock, because when tissues don't receive enough oxygen and nutrients, they will go to the anaerobic metabolism, leading to building of lactate in the blood, in the tissues and in the blood. As well as we'll do a coagulation studies, chest x-ray, very important, can give me an evidence for tension pneumothorax, for aneurysm, okay, in the aorta. We do an ECG, as we said, for looking for arrhythmia if it's a cardiogenic shock, okay, and the blood culture for septic shock and ABGs as well. If we still suspicious about our diagnosis and we still don't reach our specific type of shock, then we might do a targeted lab study or imaging, such as a CT brain, CT spine, urine electrolyte culture, and so on. And we must know that there is some drugs, okay, that we can use, like an vasoactive drugs, that can cause a vasoconstriction or play a role as inotrope or chronotrope, okay? So what the meaning of inotrope? Inotropic drug is the drug that increase the heart contractility, okay? Such as the dobutamine, and this is used when we have a cardiogenic shock. A chronotrope means that the drug that increase the heart rate, okay? So chronotrope, the drug is increasing the heart rate. Inotrope, the drug is increasing the heart contractility. Okay, and as we said, we might use adrenaline or epinephrine if it was an anaphylactic shock. And yes, so we monitor the patient frequently until he is stable, and when we define the cause, the specific cause for his shock, we can treat it accordingly to the type, and that's it.